We're going to be speaking about the assessment of long leg, a little bit on the short leg as well, and then we're going to put that into the context of the presenting diagnosis and looking for contributors and overcompensations as part of the overall treatment plan of the patient. It's a little complicated, and it's not something you're going to get in 2, 3, 4 presentations. It's something you're going to have to work at on an ongoing basis, using it on patients and fully understanding this, and also innovating. There are weak areas in this. This is still in the process of being developed, regardless of the fact. These principles have been used now for 20, 30 years. This is still a lot of areas where contributions have still been made to this, not research, hard research, but rational clinical contributions. And we're hoping that this will be you. Okay, we're going to measure this not with a tape measure, not with a grid chart, not with x-rays. Now, you know perfectly well that measuring with a tape measure has very, very poor interrelator and intra-relator reliability. Plus the fact if you're measuring in supine position, the problem you've got there is you can't measure what the foot is doing to that length, and the foot can add or subtract 2 inches from the overall length of the leg. So you can't see the compensations that weight bearing gives you for leg length discrepancies. You also can't see the effect of these compensations to the overall leg length if this isn't a functional measurement. So it's not just a matter of putting weight through the joint, but we're also going to have to watch the patient walk and see how they compensate for things as they go along. If they compensate, but no tape measure, what we're going to do is functional weight bearing assessment. So we can look at the patient standing, and we can look to see whether it's compensated or not compensated. But I don't think that's as useful as it is watching them walk. Now, one of the problems with standing is that hip extension hypermobility makes a drastic difference to the length of the leg. It increases the leg considerably. But that only becomes apparent when you're actually coming towards the terminal phase of that back leg gait. So it's when extension is needed. If you lost 50% of that extension, that won't show up when you're standing. It'll only show up when walking. So standing has its problems. But what we tend to look for is scoliosis, and the hip tends to jut out. Now, you will probably never see an adult who doesn't have a scoliosis in the lumbar spine, a small one, but this is about, in part anyway, leg length discrepancies. And if the leg length is significant, then that shift of the hip out and the scoliosis can be quite obvious. In fact, if you're not careful, you'll get this mixed up with a McKenzie shift. So if the patient's coming with back pain, and then we've also got that pelvic shifted over to one side, and you're not really careful about the way you look, which you tend not to be, you may think that they've got a McKenzie shift and you go and do the correction. You should learn quickly that this isn't actually a problem, because the first thing you want to know is this deviation antalgic or not? Now, if it's antalgic and you try and correct it, you don't have to do a full shift, just stabilize the top part with your arm and you push the pelvis over. If that's painful when you do it, then it's an antalgic shift. If it's not painful, it fairly easily corrects without pain, then it's not antalgic. So we can look for that. Now, if this long leg is uncompensated, what you'll see is that innominate crest actually riding high on that side. But if it is compensated, you may not see that difference in the iliac crest size to any great extent because of that pelvic shift over, but it may be there. But walking is the more useful one, I believe. So you're going to watch them from the back and the front. And the same when looking at the person. Sometimes it's easier to see the shift in standing in front of the patient than it is from the back, and you need to look at both ways. But you can watch walking the same way from the front and from the back. It's probably not the worst idea to look at both. Now, interestingly enough, a long leg is not the same as a short leg. This isn't a relative thing. If you've got a long leg, you have a vertical limb. You come up over that leg. And I'm assuming because that leg has less compressibility than the shorter leg, so it's much more rigid, and you vault over it, which is what the top one showing, which would be a long left leg. In fact, they're all long left, they're all left legs affected. So you come up and over, and you can see this. So you don't look at their feet, you don't look at their hips, you look at the top of their heads for that vertical gait. When you're looking at a short leg, and this is not necessarily a shorter than it should be leg, but shorter than the other one sometimes, what you'll see is that they will deviate towards the short side. There'll be a vertical, a horizontal limb, a lateral limb down towards that leg. And it almost looks as if they're going to walk off to that side. They're obviously correct. So it's actually a downward shift. You see a shoulder dip, but the whole trunk tends to move across that way a little bit. So I find this the most useful way of doing it. Now, if you actually want to measure in centimeters or inches, the difference in the length of the leg, the thing to do is keep putting shims in the shoe until the limp disappears. Then you can measure what you've put into the shoe, and that's the height, the length discrepancy. And you can correct that maximum, which you probably wouldn't do, but that would be your maximum correction if you want to measure it in centimeters and inches. But measuring with a tape measure really isn't very good because it's completely afunctional. It's just not a functional thing to do. Okay, so let's say we've accepted this as a stress fracture. You almost certainly got an image, but you've got the patient in your clinic, so you might as well keep on with this, because the fact that it turns out to be a stress fracture doesn't mean to say it should be a treatment. And rather than the patient just saying rest it, let it go, you can then talk to the doctor about what else may be stressing this out, and then have a go at treating those things. If the doctor's any good at all, he'll go along with it, rather than say, oh, that's bullshit. Just get on with it. We'll just let them rest and then run again, because it will break down again. There's no reason for it not to. So first off, the differential diagnosis of a stress fracture is pathological fracture and an overt fracture. Sometimes there's bits about the trauma that doesn't seem like it should be that stressful. But I'll give you an example. My wife fell with her hands in her pockets in the window. She slipped on some ice, she fell down, and she fractured a distal radius. Not a Colles fracture, her hand was in her pocket. But the reason, and she was menopausal age at that point, but the reason it fractured was because she came down on the edge of the curb of the sidewalk. So the pressure then goes way up, and that was enough to fracture the bone. So sometimes overt fractures are a little bit hidden as well. Anyway, we can either think about this in terms of overt etiologies or covert etiologies, hidden etiologies. So overt etiologies will include overt exercise, stupid amounts of over exercising, and trauma. So as I said previously, if you think that there is this simple over exercise, then find evidence of the same issue on the other side. The other bone should be breaking down. If all this is simple over exercise, then that bone should be breaking down on both sides. One becomes symptomatic, but the other one should be breaking down to the point where palpation for tenderness, stressing it, and so on can bring that pain on. If it doesn't, then you have to start thinking about other things. You have to. If it's trauma, then you won't find evidence of the same problem on the other side. So basically these two sort themselves out by the same test. Look for other signs of stress in that bone on the other side being positive. If it's positive, then it may well be that the simple overexercise is doing this. If it's not positive, it may be trauma or hidden covert etiologies. So as far as covert etiologies, we have long leg, a medial uncompensated torque, which we'll talk about, a medial rotation of sublux talar with tibial overcompensation, a direct mechanical stress straight onto the tibia, not the long leg, just a straight mechanical stress on the tibia, or it may be pathology again. So, or a combination. So we've got, for long leg, we've got hip hypermobility with contributors, and so, hip hypermobility with contributors. I've deliberately left out the ankle from the long leg because the ankle can also be considered producing stress on straight onto that tibia. But of course, the sublux ankle does produce a long leg anyway. The hip rotators may be weak, or the foot intrinsics may be weak for whatever reason. We talked about this before, and in that case, the whole leg is going to tend to medially rotate, which is your torque. It's not being pulled out, and the other leg and the other joints cannot compensate for it, and things start to break down. A medial subluxation of the talus is going to be accentuated force on the tibia if you're looking at an inverted calcaneus, so the foot can't flatten out, or dorsal naviculars and some of the other dorsal bone subluxations. All of this is going to tend to prevent the foot from flattening, and that stress is going to go on the tibia. And pathology, you'll find no evidence of covert etiology, or at least not enough evidence of covert contributors, in which case it almost certainly should go back to physician before you start doing too much to it. Okay, I'm tucked away in the corner here. Not enough room for me. Okay, let's look at a medial ankle pain that we diagnose as a medial deltoid ligament grade 2 tear. You've got the instability present there on stress testing, but there's no trauma. Stress testing causes pain. The patient complains of pain there when they run, for example, and it's tendon. We've made that diagnosis. So we look for possible causes here in the absence of trauma. So slow flow axoplasmic compromise, so malnutrition. You strength test looking for fast flow axoplasmic loss. So fatigable weakness through the appropriate myotome. Could be repeated external microtrauma, in which case you'll get that from the subjective exam, but almost certainly there's going to be another etiology going with this. It's the same as we talked about before. The person who's over-exercising, you would expect to see the same with symmetrical activity on both sides. One may become symptomatic before the other, but the other one should still be tender and stressed and be able to stress it to the point where it's painful. So there's probably other stuff going on with it, even if there is a history of repeated microtrauma. This can be an overcompensation for a long leg. That it's a medial ligament is breaking down. Now, this is unlikely to, in and of itself, to change the long leg into a short leg. So we can check gait for a vertical limp, and we find the cause, and then we find that it's present, and then we search for the cause of it. If it's absent, if this is a normal gait, for example, or even a low gait, then we need a short leg gait. Then we need to search for a long leg cause. Now, if we can't find it, then we have to rethink everything. This isn't caused by a long leg. That is, if we don't find a hip problem and an ankle problem. But if we do, we're going to either find the hips in trouble or the ankle in trouble, or both of them are in trouble. And it's quite possible it's going to be both of them. And there's also likely to be other contributors through there as well. Joints that can't compensate now. So this is now it becomes the effect of a long leg. We can search for other overcompensations and breakdowns. If it's the ankle, this may well be a direct stress onto the medial ligament, but either way, you still want to search for other overcompensations, and then you can treat all the etiologies and overcompensations, and that's a lot of work. Okay, so my suggestion is that you do very similar to what I've just done with you. You don't expect to get it right, you don't expect to come up with all the scenarios, but this is a good exercise for you to do. Come up with a diagnosis and work your way backwards from it as to what would cause it, and how you're going to find out whether those things are present or not. This is a very good exercise, and I strongly recommend it to you. It'll make you think about what you're doing, and also I'm trying to figure a way of putting this stuff on the exam. So just for purely pragmatic purposes, as far as you completing the course is concerned, this is what you need to be doing. If you look at Lucid Chart, I think it's lucidchart.com. but they will give you a free trial. It's an unlimited time trial, but they'll only give you 3 diagrams that you can store. But if you like doing it this way rather than pen and paper, it's probably the way to go. Anyway, I really think that this would be a very good exercise for you to try. Anyway, until next time, take care, everybody. Bye-bye.